in order to avoid repetition. So an elderly woman presented with malaria and poor feeding. She was incoherent at presentation. Her husband had to give the history. She went to bed early the day before, saying she was not feeling well. She has non-Hodgkin lymphoma and her last chemo session was 3 weeks ago. She has background hypertension, type 2 DM, and hypothyroidism, which are well controlled. Sorry. Her medication include metformin, bisoprolol, captopril, allopurinol, levothyroxine, and levothyroxine. She is hypoxic with SpO2 of 86% on room air, which improved to 92% after she was placed on oxygen. Her BP 9654, pulse rate 122 beats per minute. Her investigations are as follows: HB 8.6 grams per DL, WBC 0.6, neutrophil 0.1, platelet 446, EUCR normal, C-reactive protein elevated. So the questions are: what is the diagnosis? 2, list additional investigations needed in her management. 3, how will you treat this patient? So for the diagnosis, this is likely neutropenic sepsis. So reason being that from the history, she is on chemo and she had her last session about 3 weeks ago. She has features that is in keeping with severe inflammatory response syndrome, like pulse rate elevated, WBC that is very low. But then is a neutropenic sepsis because of the absolute neutrophil count that is less than 0.5. So now, based on NICE, the diagnosis of neutropenic sepsis in patient having anti-cancer treatment is made in patient having anti-cancer treatment whose neutrophil count is 0.5 by 10 to the power of 9 per liter or lower, and who have either a temperature higher than 38 degrees or other signs and symptoms consistent with clinically significant sepsis. So our second definition is it can be defined as a single temperature measurement of greater than 38.5 degrees or a sustained temperature of 38 degrees for more than 1 hour in a patient with a decreased absolute neutrophil count of either 0.5 by 10 to the power of 9 or less than 1 by 10 to the power of 9 with a predicted NADRI of less than 0.5 by 10 to the power of 9 over the subsequent 48 hours. Neutropenic patient with sepsis or severe sepsis may not have fever. As we see in this patient, there was no history of fever, most likely because the woman is an elderly, and also patients that are on corticosteroid may not present with fever. And based on definition of SARS, whether it's hyper or hypo, the temperature is greater than or hyperthermia or hypo is both suggestive of sepsis. So the common organism pathogen that are associated in or that are implicated in neutropenic sepsis most of the times are gram-positive pathogens like coagulase negative staphylococcus, Staph aureus, including methicillin-resistant strain, Enterococcus species, Streptococcus species, including the viridae, pneumonia, and pyogenes. But then gram-negative organisms are also implicated, like the Enterobacteriaceae, especially E. coli, Klebsiella, Enterobacter, and Pseudomonas. So the additional investigation I'll do for the patient include a full septic workup. For that, I'll do a blood culture for aerobic and anaerobic organism. I'll obtain 2 blood culture samples from the peripheral vein using Bactec bottles at 10 to 15 minutes apart. I'll do urinalysis, urine culture and sensitivity, culture of wound swab, catheter discharge, or any infection foci. I'll do sputum, gram stain, and culture. I'll check the stool for Clostridium difficile. So for that, I'll do a screening test using the rapid test, which is the reverse transcriptase PCR or the immunosorbent assay of glutamide dehydrogenase. And to confirm my test, I'll do C. difficile toxigenic culture or cell cytotoxic assay for toxin A and B. I'll do skin biopsy if there are erythematous or tender skin lesion. I'll do a liver function test with particular focus on the albumin, lactate dehydrogenase. They will all tell me about the prognosis, how to stratify my patient. I'll do C-reactive protein, although they already give it. I'll do a renal function test for the patient. So for the patient management, neutropenic sepsis is an acute medical emergency that will require a multidisciplinary approach. I will require the service of the hemato-oncologist, intensive care specialist, clinical pharmacologist, endocrinologist, cardiologist, IDU specialist, and microbiologist. But then I need to stratify my patient to know whether I'll manage her as an inpatient or outpatient using the Multinational Association for Supportive Care in Cancer Scoring Index for risk stratifying patient with neutropenic sepsis. So there are parameters and score assigned to each, for which if the score is less than 21, it indicates a very high risk, and a score greater than 21 is lower risk and may require either ward or outpatient management. But okay, I'll look at things like burden of the illness. If the illness is mild or no symptoms, I will give her a score of 5. Severe symptoms, score of 0. No hypertension, score of 5. But as you can see, our patient is hypertensive with a BP of 90, 50 something, and pulse rate of 122. And then the presence of comorbidities like COPD, a score of less than 4. But if there is no COPD or other comorbidities, score of 4. If the patient has fever at onset, a score of 3, and then age. So generally, our patient clearly will have a score of less than 21 because of her age and the other things, because she presented in a severe condition with, in fact, in shock, with a low BP, high pulse rate, and other symptoms like low WBC count. So for the immediate care, in the first hour, I want to resuscitate my patient using the ABC of resuscitation, where I maintain a patent IV line. I will check her airway and maintain its patent, ensure the patient is breathing, ensure her circulation. So for that, within that moment, I want to do the early warning scoring system. And I will also request for ICU review. These are important because they will tell me more about my patient, and then monitoring this will improve mortality. The parameters I will look for include the basic vitals like respiratory rate, heart rate, temperatures, systolic blood pressure, and estimated hourly urine output. But my 5 goal target within the first hour include IV resuscitation with IV fluid. I will use a vasopressor support for the patient because, as you can see, the patient is in shock, to maintain her BP, to improve her BP. And I'll commence our empirical broad-spectrum antibiotic therapy while I await the blood culture results and then monitor the lactate level and the urine. So the rationale for the antibiotic cover for this patient is to likely cover the causative organism. Mostly, like I said before, is gram-positive. But because bacteremia with the gram-negative, especially Pseudomonas, it can be very life-threatening with high mortality. I want to go for antibiotic cover that will include Pseudomonas. So, and another thing is the choice of antibiotic will also depend on local susceptibility pattern in that area. So it depends on what we do in our center or in the center that is involved. Therapy should be reviewed with a causative when the causative organism is identified using a blood culture result. After initial treatment, I will offer initial treatment with piperacillin and tazobactam, or meropenem, or imipenem and cilastatin as initial empiric antibiotic therapy with in a patient with suspected neutropenic sepsis. So unless if there is contraindication. So for patients that have contraindication to this, I may not give them. But otherwise, this is what I will do. But then the NICE discourage the use of aminoglycoside either as a monotherapy or dual therapy for the initial empirical treatment, unless there are patient-specific indication for that or a microbiological indication. Also, if the fever persists, because there are situations whereby the infection can be as a result of.
You have 1 minute left.
Okay.
1 minute left.
So other things I do include protective isolation, hand hygiene, full barrier, including masks, gown, gloves, and shoe. The patient may benefit from ground-side colony stimulating factor, which will increase the neutrophil count, reduce the rate of serious infection. It will decrease mortality in bone marrow transplants. Yes, and other supportive care and monitoring. If fever persists Okay, this is just a repetition. I will investigate for fungal infection and commence and treat her along that line. And such patients should also be assessed by an infectious disease physician or clinical microbiologist. So I mean, I'm referring to patients that after doing all this, their fever persists. While I investigate for the cause, I will invite the microbiology, although they're already in the picture, so they will review her. Overall duration of antibiotic is variable, but in general, if a patient has been a febrile for 5 to 7 days and has no complication, can discontinue the treatment even if neutrophil count remain below 0.5. Adjuvant therapy includes steroid, IV, immunoglobulin, activated protein C. They have all been tried, but non-improved outcome, and they are not recommended by NICE. So other recommendation include they came to this conclusion. Okay, include offering fluoroquinolone for primary prophylaxis. The guideline committee came to this conclusion after examining over 200 random control trial of primary prophylaxis, basing their decision on clinical evidence that fluoroquinolone are more effective than placebo for reducing mortality and neutropenic sepsis. We consider outpatient antibiotic therapy for patients with so this I'm talking about the NICE recommendation now. In patients with confirmed neutropenic sepsis and a low risk of developing septic complication, taking into account the patient's social and clinical circumstances, discussing with them the need to return to hospital promptly if problem develops. So I may switch from IV to oral antibiotic after 48 hours of treatment in patients whose risk of developing septic complication has been reassessed as low by a healthcare professional with competence in managing complication to anti-cancer using validated risk scoring. So this is the end of my presentation. These are my reference. Okay, my special appreciation to Chief Ijoma for the slide. Thank you.
Thank you so much, Dr. Budia, for that lucid presentation. Please, can we applaud her? Can we appreciate her in the chat room? Let's commend her for this beautiful presentation. A job well done. You're really, really appreciated. Okay, so it's time for questions, for contributions. So while we wait for contributions and questions, I have a contribution to make and then a question, Dr. Budia. Okay, so basically the organisms that are involved in neutropenic sepsis are more of the gram-positive organism that you mentioned earlier on about the coagulase negative staphylococcus organisms and then viridans. And then for the gram-negative, we have more of the beta-lactamase organisms. We know the beta-lactamase organisms are gram-negative. So, our choice of IV piperacillin and tazobactam was actually on the top because it takes care of both gram-positive organisms and gram-negative organisms that are beta-lactamase organisms, because it actually inhibits or it actually attacks the gram-positive organisms as well as the beta-lactamase gram-negative organisms, because it inhibits that enzyme because their virulent factor is the beta-lactamase. So what it does is that it inhibits that beta-lactamase enzyme that is being secreted or being excreted by the gram-negative organism. So that's why IV piperacillin and tazobactam, especially tazobactam, is used for that purpose. That's why it is actually high up there because of the organisms involved. Then secondly, if after 5 days of taking these antibiotics and the patient is still having fever, it's good to consider doing a fungal study because that can also occur in this case. Then secondly, Dr. Godia, you made mention of Clostridium difficile in this patient, to look out for Clostridium difficile. I know normally in hospitalized patients or healthcare workers who have neutropenia and then suddenly develop diarrhea, or maybe a hospitalized patient who suddenly develops diarrhea and then has a background with neutropenia, we actually look out for Clostridium difficile. I just want to know why in this patient, why are we looking out for Clostridium difficile? Like an additional thing for this patient. Thank you so much. So Dr. Godia. Dr. Godia, are you still here with us? Oh. I think she's having a network challenge. She's not on right now. I don't know if she'll be in the waiting room. Dr. Godia is actually offline. I think she's having a network problem.
No, she's muted.
Hello? Hello? It's like the host has muted me.
Oh, we're so sorry about that.
Okay, sorry.
I don't know if you got my question. Did you get my question?
Yes, I did.
Okay.
I did. Thank you. Yes, thank you. I say thank you for the comment. So yeah, because the C. difficile can be caused by a wide range of organisms, a wide range of antibiotic, which include quinolones and the penicillin, clindamycin, especially top on the list. But then this patient most likely might have been on other antibiotic even before presentation. So she's at risk of having pseudomembranous colitis, which is a form of antibiotic-associated diarrhea. So it's good to do that because patient has been unwell for some time. She might have been on antibiotic for maybe some time even before presentation.
Okay, so what do we give at that point in time? Okay, so what do we give at that point in time? If maybe you check for it and then it's present, what do you give?
Yeah, we treat her depending on the severity. In mild situation, we give oral metronidazole. In severe cases, we give IV vancomycin, and then refractory, we go up higher. We join the IV and the oral metro.
Yeah, good. Good. I wanted to hear that from you. Thank you so much. Metronidazole, very good. Thank you so much. Okay, so going into the chat room, everyone is applauding you for your presentation, your beautiful presentation, excellent presentation, fantastic presentation. I'm yet to see questions in the chat room, but I have someone's electronic hand up, and that is Dr. Jamila. Dr. Jamila, please, you have the floor to ask a question or make your contributions. Thank you.
Good morning, all. Thank you, Dr. Godia, for this wonderful presentation. But looking at the scenario, I think all the 3 cell lines are low, not only the WBC count. So what I feel is that apart from the cultures, we need to take bone marrow specimen for diagnosing either the patient developed aplastic anemia from the chemotherapy. That is the only contribution I have. Thank you.
Yeah, thank you so much. Thank you.
Thank you so much, Dr. Jamila, for that beautiful input. I'm also seeing Dr. Lawrence Adeye's electronic hand. You can please ask your questions or your contributions. Thank you.
Thank you. Good morning, all. Thank you, Dr. Godia, for the presentation. I just want to know if you are to be the one in the exam, you are asked how to manage this patient. In addition to the antibiotics, would you like to give antifungal or antiparasitic or antiviral in addition to the antibiotics? But it was part of your the literature, everything was lumped up. Then as part of the investigation, you mentioned you are going to do bone swab, MCS, catheter. Is it for this patient or for generally for any patient that has neutropenic sepsis? That's my question, Dr. Godia.
Okay, thank you so much, Chief Lawrence, for the question. Yes, so like I said, normally we treat the patient if at day 5, day 6, there is no response. There is need for me to evaluate the patient for possible fungal or parasitic infection. So I will do for fungal and parasitic, anyone that comes positive is the one I will face. Yeah, because if she doesn't respond to antibiotic, it's likely that what she's having is not from bacterial etiology. Most likely it's fungal or parasitic. So I will do the fungal and do the parasitic, and I will treat the positive one at the end of the day. Sorry, what is the second question?
He was asking for the same patient, you're going to do a wound swab, catheter, or for the same patient, why all those investigations?
The patient is septic, so I need to do a full septic workup for her. If she has a wound, I will do a wound swab. If she has an indwelling catheter, I will take it out. And use the tip for culture the tip. So this kind of patient, I wouldn't want to leave her on. I will use rather a condom catheter for her. I wouldn't want to leave any focus of infection in her, because as you can see, she is very sick and she is likely to develop infection from any sort. So it depends on what she has, but then is a general workup for a patient that is neutropenic or a patient that is septic. So if there is a catheter, I will take it out for culture. If she has a wound, I will take it. I will take a sample for culture too. Thank you.
Okay, thank you, Dr. Good. And maybe like an add-on, if you look at the history, there was actually no focus of infection. So I think that's why we were kind of doing all of those investigations. The history did not pick out any focus of infection. So I think that was why you mentioned all of those investigations, to know where the focus of the infection was coming from. That's just my thoughts. Okay, thank you. Okay, so in the chat room, Dr. Momodi is saying for pseudomembranous colitis, stop offending drugs first, then you treat. Then also he went further to say pulse tubing can't be used on the women. Thank you so much, Dr. Momodu, for that great contribution. I initially saw Dr. Ikele's electronic hand up. I'm not seeing it again. Okay, so Dr. Sani Abubakar, you can actually have the floor. You can ask your question or make your contributions. Chief
Thank
Shitu,
you very much for
the
wonderful presentation. Thank you for the wonderful presentation. A follow-up. Mine is just comments. We should just remember that Clostridium difficile infection is not synonymous with pseudomembranous colitis. I'm sorry, maybe because I'm an ID, SRNID, that's why. It's usually pseudomembranous is usually the extreme form. So it's a severest form, and it's usually in colonoscopic diagnostic. You have to do endoscopy before you establish that diagnosis. It's not a clinical diagnosis. Secondly, we don't do catheter MCS now. If you suspect catheter-associated urinary tract infection, that's COPD, we are expected to remove the catheter. If you think the patient needs the catheter, that means the benefit outweighs the risk. You can pass the catheter, then you can do a procedure to collect your urine sample to establish diagnosis. Because generally, catheters usually are nick for biofilm formation for some bacteria. So if you use it, there's every tendency you're going to culture usually just colonizing organisms rather than the pathogenic organisms. So most of the times you're expected to take a flowing urine, a midstream urine. Usually you use your clamp or otherwise to take the sample. Then in case of neutropenic sepsis, anytime you're describing neutropenic sepsis, you should be seeing go around bacteria, fungi, and viral. That is what Dr. Ade was trying to mention earlier. Even the fact that you have established there's bacterial infection, you have to be very careful because many cell lines of immunity are affected. And as such, you should be seeing covering or attempting to cover or evaluate for those. So thank you very much.
Okay. Thank you so much, Dr. Sani, for that great contribution. Okay, so in the absence of questions and contributions from participants, I'll move over to our chiefs. Okay, I'm seeing Chief Shitu's electronic hand up. Chief Shitu, you can please have the floor. Thank you, sir.
Hello, good morning. How are you? Yes, I think the last speaker had referenced the things I wanted to say. One is that do not culture a urethral catheter tip, else you will just get all sorts of things. And none of them will be the offending agents, okay? So the only catheters you can actually culture the tip is blood-borne catheters. So central catheters and things like that are the ones you can actually culture, send for culture. Okay, so you don't send urethral catheter culture, tip for culture. What you basically do is take a sample of the urine, like the last speaker said. Either you do midstream or you take it from, use a clean needle and take it from a closed catheter. And then take what you're doing or do a suprapubic tap for urine or something. Yeah, so that's what I wanted to add. But the speaker has done very well. And the contributions are on point. Thank you.
Okay, thank you so much, Chief Chitu, for that great input you just made. So I don't know if any of our chiefs. Okay, Chief Remigos, you can please have the floor, sir. Thank you.
All right. Thank you so much. It has been a beautiful presentation and awesome contributions. Okay, so I just have one or two things. So the first one is, I don't know if you mentioned procrastinating. I think can be useful in the investigation of the patient too. Okay, so I don't know if you mentioned that. So then serum procrastinating, and then I just need a clarification. I don't think it's clear yet. You know, in practice, since I'm in practice, and anytime we hear febrile neutropenia, everybody seems to start parrying at it. All we want to do is to give blunderbuss, give everything, antibiotics, antifungal, antiviral. You know, that has been my kind of mindset. So I still need some clear clarification about that, especially in our setting where, for example, some centers say they don't even have back tech and all that, and even to do your blood culture, it will take a long time. You are treating patient, the fever is not coming down, you've not gotten any cultures and stuff like that. So maybe our infectious disease experts can tell us categorically that no, blunderbuss is not it. You can't do that. Just give antibiotics initially. When do we now start considering antivirals, antifungals? Because I know that I don't know the centers that do fungal cultures in this country. So thank you. That's just it's like a clarification that I'm seeking. Thank you. I hope we heard me. Sorry.
Yes, sir, we did.
Okay. Yes, sir. Okay, let me mention something, sir. Sorry, I'm Dr. Mohammed Sanabakar, SR infectious disease. The word you mentioned is right, and that is problem of management of neutropenic sepsis, especially in resource low setting. Very, very challenging with a lot of unpredicted outcome. What the guidelines say is it should be directed therapy, meaning you should know what you are treating. That is the most important, because you have to realize this patient is already immunosuppressed with less cell line of immunity. At the same time, also, it's a patient that has ongoing comorbidity, maybe malignancy or an advanced end organ damage. So combining many antibiotics with potential hepatotoxic or endotoxic damage may be counterproductive in the management of the patient. However, if you're in a setting where you're not sure of what is the commonest organism they usually come down infection with is bacterial infection, and most of the times are those very toxic organisms like Pseudomonas, like MRSAs, Staph aureus, like Enterococci, and a lot of organisms that produce the ESBL, that's extended spectrum beta lactams. You're expected to give a drug that cover for an extended spectrum beta lactam. That's you either use imipenem or piperacillin tazobactam. In this scenario, you are not going to say, let me start with the small one, penicillin and picolex. No, they're already immunosuppressed. So you start hard and start very well, so that there is no, because once you have drainage and organ damage, there may be problem with the patient recovery and even the outcome. Now for the antifungal antiviral, it's a bit dicey, and what we encourage and what is usually advocated is if you are not sure of the culture, because mycology is something that is difficult to do even in our microbiological lab to test for bacteria. Now, the worst is the viral screen or even testing. So what we are expected to do is, if you think the patient has telltale sign of the ongoing fungal infection, or he's in an area where there are some clinical evidence. Example, if you have seen, if along the culture, or a swab or something, you saw high K, or you see some cell, you don't have to speciate. At that point, you can just decide, okay, which site is it? Is it the oral cavity? Is it the skin? Okay, what's the commonest fungal infection I usually find there? Okay, can we treat it, or can we give prophylaxis so that to prevent untoward infection? So it's always difficult to adhere to the guideline, and also balancing it with the practical application on the bedside. But that is why once you have neutropenic sepsis, what is advised is you seek for an advice of the infectious disease on ground or clinical microbiologist that will tailor the management. In our clinical setting, For mild to moderate neutropenic sepsis, combination of augmentin and ciprofloxacin is quite effective for mild to moderate. But if you're dealing with severe, you should be seen covering the ESBL and other organisms. I don't know whether what I have said is clear. Thank you.
Thank you so much, sir. Thank you so much. Chief Christabel, I don't know if you have any contributions or questions.
Let's move, please.
Okay,
Thank you.
Thank you, ma'am.
Thank
All
you,
right.
Dr.
Okay, so,
Godia.
okay, thank you so much, ma'am. Okay, so the next presenter is Dr. Afyong Basi, who is going to take us on practice question 4B. Dr. Afyong Basi, you have 10 minutes. You can please have the floor. Thank you.
Good morning, all. I'm presenting practice question 4B, April 2024. The next slide. A 20-year-old nurse intern has had malaria and fever for more than a week, which she attributed to work stress. She took anti-malarials, but there was no relief. And a matron told her to take antibiotics as well. When her symptoms persisted, she came to see you. At that time, she had developed sore throat, rash, and tingling sensation in her ears. 1, list 6 additional questions you will ask her. 2, list 4 differentials. 3, what is the most likely diagnosis? Please, next slide. 4, what is the vector for the disease? What is the mode of transmission? Which investigation will you do? How will you manage her? List 4 complications that can result from this disease. 9, what is the prognosis? Now, please, can you? Okay. Now, the 6 additional questions I will ask her, I actually listed more than 6. Is there any history of vomiting or diarrhea, abdominal pain, jaundice, dysphagia, shortness of breath, abnormal bleeding, joint pains, retrosternal pain, chest pain, facial swelling? Is there any change of urinary output or hearing impairment? Any history of seizures? And then you try to find out if there's any history of contact with persons with similar symptoms, especially in the emergency unit she works. Did she have any patients with similar symptoms? Any history of recent travels to endemic areas and contact with rodents? Then the next question is, okay, 4 differential diagnoses. First on the list, Lassa fever, malaria, typhoid fever, sepsis, Ebola, yellow fever, pharyngitis, and leptospirosis. Please, next slide. What's the most likely diagnosis? Lassa fever. Next slide, please. What's the vector of the disease? The vector of the disease is a multi-mammate rat, Mastomys natalensis. It's said to have many breasts, multiple breasts. That's why they call it a multi-mammate rat. Please. What's the mode of transmission? Rodent to human, human to human. Rodent to human through inhalation of aerosolized viruses, contact with urine and feces of these rats, inhalation of the virus, catching and preparing these rats as food, ingestion of food or materials contaminated by infected rodent excreta. For human to human transmission, inhalation of aerosolized virus, direct contact with blood tissues, secretions, and excretion of infected humans, and needle stick injuries, which we think this nurse had. Please, next slide, please. Even though this wasn't part of the question, I just included it, the risk factors for Lassa fever: contact with any infected person in the community, contact with an infected patient, exposure to the rats, exposure to body fluids or tissues of infected patients, and travel to endemic regions like Sierra Leone, Liberia, Guinea, and Ghana. Next slide, please. Which Which investigation would you do? I'll start with supportive investigation like full blood count, E and U for renal function test, liver function test, urinalysis. Since she has sore throat swab for MCS, clotting profile, ECG, and chest X-ray. Now the diagnostic investigation, you do ELISA for antigens, IgM and IgG. For the Lassa fever, you do Lassa fever reverse transcriptive polymerase chain reaction, and then isolate the virus using immunochemistry, and then you do throat, that is for the specimen, you do throat swab, urine swab, you do urine, that is you do take specimens for throat swab, urine or serum. Next slide. How will you manage her? Supportive therapy, admit the patient to an isolation ward. Give IV fluids, especially crystalloids. Give pain relief. Blood transfusion, because the patient would apparently be anemic, hematinics, antibiotics, vasopressors. And then definitive treatment is ribavirin, and is most effective when it started within the first 6 days of illness. Next slide. Now, there are two regimens for the treatment, the McCormick and IRWA regimen. IRWA regimen is easier because of the dosing periods. It's easier to give. McCormick, you have to give many times. And for the McCormick regimen, the loading dose is 33 milligrams per kg. That's what you give start. Then you, from day 1 to 4, you give 16 milligrams per kg 6 hourly. And from day 5 to 10, you give 8 milligrams per kg 8 hourly. That is, you treat it for a period of 10 days. Now, in the IRWA regimen, loading dose is 100 milligrams per kg in 2 divided doses. That's loading dose. That's 2/3 is given start, 1/3 is given 8 hours later. Then the 2 and 7, you give 25 milligrams per kg daily. That's a single dose. Then 8 to 10, you give 12.5 milligrams per kg daily in a single dose. Please, next slide. The 4 complications that can result from the disease: acute kidney injury, severe central nervous system features. They can have seizures, restlessness, coma, confusion. They can have sensorineural deafness, severe bleeding, respiratory distress, severe anemia requiring blood transfusion, sepsis, and hypovolemic shock. Please, next slide. Next slide, please. What's the prognosis? Abnormal bleeding, encephalopathy. The patient can have shock, and then poor prognostic factors. You find that if a patient was commenced late on ribavirin, that is after 6 days of illness, is poor prognosis. The patient can have acute kidney injury, and if the age is less than 5 years or greater than 50 years, that's poor prognosis. And then elevated serum AST, seizures, and alteration in consciousness. This next slide. So I'm going to go through Lassa fever. These are the headings. Next slide, please. Next slide, please. Lassa fever is one of the viral hemorrhagic fevers. It's caused by Lassa fever virus, which is an enveloped, single-stranded, bisegmental RNA virus of the RNA family.
Hello, Dr. Apion.
Yes?
Hello, Dr. Apion. For want of time, we might have to stop here. Thank you so much, so that we'll take questions, comments. We still have a third presenter. Like last time, we keep talking about.
Sorry, is it up to 10 minutes?
It's about that, not yet, but about that. You have like 1 minute. You have like 1 minute, 8 seconds.
All right. It was first discovered in Lassa town. And
Yes, we're appealing to you. Let's take comments. So that we'll keep to time.
Okay.
Thank you. You can summarize it quickly. So I will take comments and questions.
All right. All
Thank
right.
you.
Okay. Lassa fever was first discovered in Lassa town in Borno State. It affects all ages and both sexes. It's endemic in Nigeria, Sierra Leone, and portions of West Africa. And then we just had an outbreak. Yes. Yes.
Why don't you just tell us about the pathophysiology so that just tell us about the pathophysiology so that we'll have that. You are going to attack this today, so we'll see it later.
Okay, all right. Okay, it's under the pathogenesis. It undergoes cellular entry via endocytosis using the alpha dystroglycan cell surface receptor on the endothelial and dendritic cells. So when it enters the endosomes, it now evades the endosomal degradation using envelope, that is, has envelope proteins. So it now evades the degradation using these envelope proteins, which mediates a pH-dependent binding and membrane fusion. Now, you have intracellular RNA synthesis, which is initiated within the L polymerase enzyme, and then this uses the eventually you have synthesis of viral ribonucleoproteins, that's RNP. Now the end result is you have vascular dilatation and increased vascular permeability. Now prompt host immune response is critical for host survival, and fatal Lassa fever is often characterized by impaired or delayed immunity. So the incubation period is usually 5 to 21 days, and then diagnosis I've mentioned, and then precautions when giving it. NSAIDs are contraindicated due to risk of bleeding. You avoid intramuscular injections to prevent hematoma formations. You use cotton wool to clean the mouth of patients instead of hard toothbrush. And then any skin ulcers should be cleaned and dressed gently. Then do not enter a patient's room or get in contact with a patient suspected or confirmed Lassa fever. And that is, you must enter a patient's room, you must wear PPE. Now I mentioned the differentials, and then discharge criteria. If you carry out RT-PCR out at day 10 and it's negative and patient is afebrile, then you can discharge the patient. For symptomatic patients with negative PCR, you discharge into an appropriate ward and for subsequent management. Or if the RT-PCR is positive after treatment and there are no symptoms suggestive of Lassa fever for 22 hours post-op, so you can discharge such a patient. And then if patient is still positive at day 10 and still symptomatic, treatment can be extended for 5 to 10 days. And then you follow up the patient every 3 weeks and monthly for the next 3 months. And patients should be, after discharge, you should evaluate the patient consistently for hearing loss and other complications. And then nursing mothers should not commence breastfeeding until breast milk tests are negative. And then semen should be tested. It can be sexually transmitted. After 3 months, and patients advised to avoid unprotected sexual intercourse during this period. And if semen remains positive, patients should be counseled to use condom. So you have control.
Okay, Dr. Pasi, I think we should round off. Thank you so much. Thank you so much. We would have the slide. We will go through it. Thank you for this extensive presentation. You're very much appreciated. Thank you so much. Please can we appreciate her in the chat room? It's now time for questions and contributions. It's time for questions and contributions. Okay, it seems it's well understood. Okay, so I'll move over to our chiefs. I don't know if we have
Mamadou Jafaru and is up. I don't know if you can allow it.
Okay, all right. Okay. All right, Dr. Mamadou, you have the floor, please. Thank you.
Thank you so much. Morning, our teachers and colleagues. I just wanted to point out some additional factors in terms of the complications, please. The sensorineural hearing loss can occur in about 30% of the patients, and most times it's permanent. You might not be able to take that completely. Then also, there are some other chronic complications that could occur, even alopecia, iridocyclitis, and transient blindness. They can also occur in this Lassa fever. Thank you so much.
Thank you so much, Dr. Mamadou, for that wonderful input. So everyone is applauding you in the chat room. Okay, so in the absence of questions and contributions from the participants, we'll move over to our chiefs. Please, our chiefs, any questions, contributions as regards the presentation? Okay, thank you so much once again, Dr. Bassi. So move over to the third presenter, who is Dr. Ogundade. Sorry, your name is Dr. Ogundade, who is going to take us on practice question 5B. Ogunmodede Adebimpe. Dr. Adebimpe, you can please have the floor. Thank you so much. You have 10 minutes to present, please.
Okay, am I audible, please?
You are, but we're not seeing your presentation. We're just seeing your beautiful face.
Okay, can you see my slide?
No, we're not seeing your slide yet.
Okay. Can you see my slide now?
We are seeing your screen, but we're not seeing your slide yet.
Can you see it now?
Yeah, we're seeing it. Thank you. So you can have the floor. 10 minutes, please. Thank you.
Okay. Good morning, facilitators, teachers, senior colleagues, and colleagues. I'll be presenting practice question 5B, April 2024 exam. The question reads thus: a 60-year-old man presents with 3-month history of cough with whitish sputum production and difficulty in breathing. No fever. He has a significant smoking history of 20+ years. He's a construction worker and has significant exposure to dust and fumes at his work. On examination, he had bronchi. His FEV1 over FVC is 0.6, and the chest X-ray did not show features of bronchiectasis and lung fibrosis. Question 1, what is the most likely diagnosis? What is the pathophysiology of this disease? What maneuver will you do during spirometry? What are the differential diagnoses, and how will you differentiate this condition from the closest differential? And what non-pharmacological and pharmacological ways will you manage this patient? So the most likely diagnosis is chronic obstructive pulmonary disease, COPD, based on the 3-month history of cough, which is productive, the difficulty in breathing, the significant smoking history, which is 20+ years. Then is a construction worker with significant exposure to dust and fumes at work. Then examination finding of bronchi and the spirometry, which is FEV1 over FVC of 0.6, which is less than 0.7. The pathophysiology of this condition can be explained based on the etiology, presence of the host factor, presence of noxious stimulants like smoking and pollutants, and these cause chronic inflammatory changes and structural changes in the lung, leading to oxidative stress, protease-antiprotease imbalance, presence of inflammatory cells and inflammatory mediators, and they eventually lead to airflow limitation, gas trapping, mucus hypersecretion, and eventually pulmonary hypertension. And they cause persistent airflow limitation and present with clinical features like cough, dyspnea. They can have exacerbations, and with each exacerbation, there's worsening of the condition, and they also develop comorbidities. Then what maneuver will I do during spirometry. First, I will instruct the patient to get a good seal around the mouthpiece of the spirometer. I'll ask the patient to rapidly inhale maximally and without delay, then blow out hard as fast as possible and to continue to exhale until he or she can blow no more. Then other instruction I will have to give the patient would be to avoid short-acting drugs within 4 hours of testing. Long-acting drug, inhaled drug should be avoided for about 12 hours prior to testing. Smoking should be avoided for 1 hour or more. Then salbutamol inhaler should be given like 400 micrograms. That's after the first recording. Should be given the patient should have 400 micrograms of salbutamol, which is four puffs within 30 seconds interval, and this should be between 10 minutes and up to 15 minutes. What are the differential diagnoses and how do I differentiate it from the closest diagnosis? One of the first differential diagnoses will include asthma, and that is still the closest differential. Others are congestive heart failure, bronchiectasis, tuberculosis, and obliterative bronchiolitis. Differentiating between asthma and COPD can be based on starting from the history, the examination finding, the investigations, and the management, and some of these differences have been listed on this slide. Usually bronchial asthma starts within like less than 30 years in about 70% of individuals, while COPD will start after 50 years. And the pattern of bronchial asthma is paroxysmal and episodic, while in COPD is usually chronic and progressive. History of cigarette smoking is not really significant in bronchial asthma, but it's common in COPD, like we have in the patient we discussed earlier. The nocturnal awakening is commoner in asthma because of the steroid dip. In asthma, they usually have they have worsening symptoms over the night, but in COPD, it's rare. Then there's a background history of atopy in bronchial asthma in about 50% of adults, while it's just in about 15% in COPD. Chest X-ray is usually normal in bronchial asthma, while in COPD, chest X-ray can be increased or decreased vascular marking, and there's usually features of hyperinflation. Then the reversibility test based on spirometry studies is actually very important in differentiating bronchial asthma from COPD. In bronchial asthma, after the first values have been taken in during the spirometry, then there's usually a reversal of about greater than 15% after using bronchodilators in asthma, whereas it's less than about 12% in COPD. So the reversibility test is actually
Dr. Bimpe, you can't be heard. I don't know if I'm the only one, but I can't hear her.
I can't hear too.
Yes, you can hear her too.
Dr. Bimpe, we can't hear you. I think she's having a poor network. She's actually offline right now. So I don't know. Let's just wait a little more, 1-2 minutes for her, please. Yes. Yes,
okay, so for the non-pharmacologic therapies, okay, so for the non-pharmacologic therapy and pharmacologic therapy include use of bronchodilators, which can be inhaled. Usually, the pharmacologic therapy can be divided into inhaled and oral systemic therapy, while the non-pharmacological therapy will be listed later. So for the pharmacologic therapy, the inhaled therapy include the bronchodilator and they include the short-acting bronchodilators, that's the SABA, that's the salbutamol, tebuteline, while the short-acting the short-acting muscarinic antagonists include the ipratropium bromide. The long-acting beta-agonists include the salmeterol, formoterol. The long-acting muscarinic agonists are the tiotropium. The corticosteroids, inhaled corticosteroids include the beclomethasone dipropionate, and it can be a combination of these two drugs. Other pharmacologic therapies include the oral corticosteroids, oral theophylline, oral mucolytic therapy, and antioxidant agents. When there are complications like in pulmonary hypertension, one may need to give phosphodiesterase type 4 inhibitors. For the non-pharmacologic therapy, it's important to advise the patient to stop smoking, nutritional support, oxygen therapy. The long-term oxygen therapy has been shown to improve the quality of life in patients that have about 15 hours of oxygen per day. Then vaccination is also important. Pulmonary rehabilitation, non-invasive partial pressure ventilation in some patients, and surgery. Then, these are indications for the long-term oxygen therapy. Then, just a brief overview. The newer phenotypes for COPD include chronic bronchitis, emphysematous type, and the mixed phenotype, that's overlap of COPD and asthma, and there's a bronchiectasis phenotype. These are the risk factors, host factors, and exposure: alpha antitrypsin deficiency, sex.
We have 1 minute left.
Oh, okay, all right. So I've discussed the pathophysiology, then the cell and mediators involved. These are the cells, and it will eventually lead to mucus hypersecretion, fibrosis, and alveolar wall destruction. The diagnosis, symptoms, presence of risk factors, and spirometry. Then the gold criteria for diagnosis of for grading COPD 1, 2, 3, 4, when the FEV1 is greater than 80% in stage 1, which is mild. If it's between 50 to 80% of predicted value, that is 2, which is moderate. If it's between 30 to 50% of predicted value, that is stage 3, severe. And it's very severe when it's less than 30%. So basically, the management include assess and monitor the disease. One could assess the symptoms by checking for the COPD assessment test, modified medical research council scale for measurement of the dyspnea. Then one would assess the degree of airflow limitation with the use of spirometry. One would assess for the risk of exacerbation and other comorbidities. Then this is a table for the management grouped into A, B, and E, depending on the MRRC, CAT score, and the exacerbation value. So these are the multi-organ complication of COPD: anorexia, depression, osteoporosis, lung neoplasm, core pulmonale, and muscle wasting. Thank you very much.
Thank you so much, Dr. Bimpe, for this brilliant presentation. Very much appreciated. Please, can we applaud her in the chat room for preparing such a beautiful presentation? Okay, so in the chat room, Dr. Olalekan is saying, thank you for the lucid presentation. You mentioned that reversibility test for bronchial asthma is greater than 15% and COPD less than 12%. My question is for reversibility tests between 12 and 15%. What does this suggest? Well done.
Okay, thank you. I think before now, we used to know the reversibility test to be less than 12%, but I think the last time someone discussed this, we were told that it's now 15%. I actually don't know what is between 12 and 15%. I would need the help of the pulmonologist to assist with that.
Okay, Dr. Mamodu's hand is up. He's a pulmonologist. Dr. Mamodu, you can please have the floor. Thank you.
Okay, thank you so much for the question. I just wanted to clarify some issues. One, the airway reversibility. Typically, if we have the reversibility, it's within greater than 12% or 200 mils. That confirms asthma at that airway limitation level. Okay, and we definitely would do it based on the percentage and the volume. So for COPD, it's not reversed, okay? It's not 15. Then the newer one is to use less than 10% in terms of reversibility, but there's a different formula you calculate that, so I won't bore you, but it's better to just stick with the 12%, less than 12%, less than 200 mils if it doesn't reverse. So you actually do that's in terms of the airway limitation which is reversed when giving bronchodilators for asthma, but not reversed for COPD. Then you made mention of giving phosphodiesterase 4 inhibitors when they have pulmonary hypertension. No, you don't. For COPD, pulmonary hypertension, you don't give even the you use the phosphodiesterase 5 inhibitors, all those prostacyclin analogs to actually treat pulmonary hypertension. But when there's COPD, they are not allowed. They are vasodilators and they can worsen the condition. So the preferred treatment is LTOT, just the oxygen, because at that time it's very, very bad. So you don't want to give them those vasodilators. You avoid all vasodilators. Then also for this particular patient, sorry, there was a question, there was something you mentioned that I'm not remembering now, but outside that, those non-pharmacological, okay, it's quite important. I didn't hear pulmonary rehabilitation. I don't know if you mentioned that. There's been newer things to show that patients with COPD, mortality is reduced. There's one pharmacological and about 5 non-pharmacological. The one single pharmacological is the triple therapy, where you use the triple therapy, that's LAMA, LABA, ICS. And to point, the roflumilast, the phosphodiesterase 4 inhibitors, there are certain algorithms actually with guidelines, most especially with GOLD, whereby you progress from using the LAMA, LABA combination to even adding the ICS, just as you said in that AB treatment group. But when they tend to fail, you might now move to the roflumilast, or if you see that they have chronic bronchitis alongside and it's not working, and then you now put it. Then also for those who are smoking, you might now still move to azithromycin, you understand, to cover up. When you stepwisely increase from LAMA, LABA, ICS, and yet they are still not doing very well, you want to go to those phosphodiesterase 4 inhibitors. That's why they are there, not for the pulmonary hypertension. So it's very key now. Vaccination too is very important for patients with COPD. You want to prevent them from having those recurrent infections as part of the what they call it now, preventive measures for them not to get infected. Respiratory syncytial virus is very, very important too, that's been added into it. COVID too has evidence now that we should vaccinate people with COPD for COVID. There are other ones based on the pertussis, even pertussis, you understand, in terms of local coverage of those organisms. You can also vaccinate the COPD patient. Then the oxygen therapy. Sorry, the non-pharmacological. Sorry, I was just a bit not to there, but to be mentioned the specific 5 non-pharmacological therapies that could help reduce mortality. The oxygen is there. The use of NIPPV is there. The smoking cessation is there. Pulmonary rehabilitation is there. Vaccination is also there. Thank you so much.
Okay, thank you so much, Dr. Mamadou, for that cumbersome input. So Dr. Ekele is saying, thank you so much for the beautiful presentation. You spoke like a pulmonologist. So in the absence of questions and contributions from the participants, we move on to our chiefs.
Dr. Ekele,
okay, you can speak. You can speak, please, Dr. Ekele. Thank you.
Well, good morning, my teachers and colleagues. Dr. Bimpe, thank you so much for the beautiful presentation. You really spoke like a pulmonologist. Okay, Dr. Mamadou has really talked about so many things I wanted to add, but also let me just add that in your treatment, you said oral corticosteroids and antibiotics. Actually, we don't use oral corticosteroids routinely, except they're coming in exacerbation. Then you give a short course for 5 days, and then the antibiotics do not routinely, except they are not doing well on the regular bronchodilators. You can use azithromycin because it has anti-inflammatory properties. And then when you spoke about the spirometries, you really talked about the precautions you would take, and the drugs and all that. So I just wanted to add also no alcohol intake before the procedure, because it could interfere with cognition, no wearing of tight clothes. Then you also rule out other contraindications to spirometry. And then when you do the test, apart from the 12% or 200 ml increase in FEV1, you can also look at the ratio. So in COPD, the ratio, that's the FEV1 FVC ratio. There will be no reversibility at all. You know, that the pulmonary rehabilitation you mentioned is so important, and it has other non-pharmacological approaches as part of it. Even nutrition is part of it, because low BMI is a poor prognosis in COPD. Then medication adherence, inhaler technique, very important. Assessing for body health is also very important. Okay, those are the ones I can remember for now. Thank you so much. Thank you so much.
Thank you, Chief. Thank you.
Okay. I think there's a question for Dr. Momodu. I don't know if we had that time, that particular time. Okay, so maybe I'll just really fast. Well done for the wonderful presentation. I don't know if Dr. Momodu can help add the explanation of pre-COPD and PRISM in the 2023 GOLD guideline. Was a bit confusing for me. Maybe he'll send it to the room, to our WhatsApp group. He'll screenshot and send it to our WhatsApp group. Then the second question is, how long do you use the azithromycin when the need arises? Thank you. I think for that question,
Dr. let Dr. Ekele or Dr. Mahmoud answer the questions. No, we're recording this. And this COPD is a topic we've not done before.
Okay.
So any question from the participant will encourage that. But although we're looking at time, but these questions are quite important so that everybody will benefit, and even subsequently to be on record that this was addressed. Thank you so much, Dr. Kalamama.
Thank you so much, ma'am. Okay, so Dr. Mamadou, please go to the chat room. There's a question for you and Dr. Ekele. Thank you so much. Dr. Mamadou, Dr. Ekele.
Okay, so let me just add for the PRISM, it means preserved ratio impaired spirometry. So sometimes you could have a very confusing spirometry results where you have the FEV1 and FVC are both reduced, but the ratio is preserved. You know, in such case, we call it preserved ratio impaired spirometry, because normally in a restrictive defect, you expect that the FVC will be reduced, and then the FEV1 will be, even if it's reduced, just mildly reduced or mostly normal, and then the ratio normal. But when both of them are markedly reduced and then the ratio is preserved, we call it preserved ratio impaired spirometry. Then for the pre-COPD, sometimes you get like an obstructive spirometry in people who are younger. You know, they have symptoms, and you don't expect that in younger people. So call it pre-COPD. And then there was one other question. I know Dr. Mamodo add.
Okay.
Sorry. Okay, for the azithromycin. So when you use it, mostly you give it 3 times in the week for 6 to 12 months. You know, because it's got mainly not because of the antibiotic effect, but because it has an anti-inflammatory effect. So you give it for like 3 times a week for up to 6 months. Okay, thank you.
Thank you so much.
I think I'll tell more about it today.
Okay, thank you so much, Dr. Ekele, for that contribution. Thank you so much. We really appreciate it. Okay, Dr. Momodu, I don't know if you have any addition to make or move over to our chiefs. Dr. Momodu. All right, so in the absence of further contributions, move over to our chiefs to please make their contributions and questions. Thank you so much.
Sorry, hello? Dr.
Hello, sir.
Yes, sir. Please, quickly, there's a particular question I feel as if maybe I didn't get it correctly. Could she just go back to the question? There's one question about what maneuver. I'd like to see that question again.
Okay.
The maneuver.
Dr. Bimpe, I think it's the question itself is what it's asking for.
Not your answer, the question. Hello? Yes. So you said, what maneuver will you do during spirometry? I felt as if the maneuver is a single maneuver, but you said a lot of things. So I'm thinking that maybe that maneuver is just the reversibility test. That's my thinking. Because they asked for one specific maneuver, but you said so many things. So I was wondering if there's a catch in that question. Is there a particular maneuver that they are talking about, like maybe the reversibility test or something? Or is there another maneuver they are talking about? Because you said a lot of things. And that question seems to specify one thing. What maneuver, not what maneuvers. So that's just the case I was thinking that maybe we didn't get right or something.
Okay, Chief, can I say something? Hello?
You can go ahead, Dr. Ekele.
Can I say something?
Go ahead, please.
You can, Dr. Ekele.
Okay. So when I saw that question, I was actually thinking it's the reversibility maneuver, because that's how exactly you differentiate between asthma and COPD. When you do that's the main way to differentiate, apart from the history and other investigation findings. One of the way on spirometry to differentiate them is the reversibility. But my senior colleague, Dr. Fei, was like, what they wanted was that first expiratory maneuver. That's what they actually wanted. You know, the day she spoke about this question on the group, she said it was the first expiratory maneuver they wanted you to talk about, not not really the reversibility. So they wanted to hear you say that the spirometry is usually a first maneuver. So the patient inhales maximally deeply and then exhales forcefully and completely. So I think she said that's what they wanted.
Okay, that's fine. Thank you so much for the clarification.
Okay, Chief Christabel, I don't know if any of us, Chief Christabel.
Yes, thank you so much. Thank you, Dr. Kalamama, for anchoring. Dr. Ekele, thank you. The presenter, Dr. Godia, Dr. Afyong, and then Dr. Gumo Mudeli. I don't know if I got the last name, but please bear with me. Thank you so much for quite a lucid presentation. All of you did so wonderfully well. Thank you, Dr. Mahmoud Jafar. You see, I'm glad you